Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Cyclic antidepressants are a group of pharmacologically related xenobiotics, primarily recognized for their tricyclic chemical structure. However, some such as maproteline are tetracyclic, and amoxapine has a dibenzoxazepine structure. Historically, these agents were the primary pharmacological treatment for major depression in the United States from the 1960s until the late 1980s, with imipramine being the first introduced in the late 1950s. Although their use in treating major depression has significantly decreased due to the availability of safer alternatives like selective serotonin reuptake inhibitors, cyclic antidepressants are still prescribed for various other psychiatric and medical conditions, including chronic pain syndromes, migraine headaches, and obsessive-compulsive disorder. A crucial characteristic of cyclic antidepressants is their low therapeutic index. This means that even a slight increase in serum concentration beyond the therapeutic range can lead to toxicity. Severe toxicity most commonly results from acute intentional overdose, but mild to moderate clinical toxicity can manifest even at therapeutic doses. The potential for severe cardiotoxicity in cases of overdose makes these medications a significant life threat. They remain among the leading xenobiotics associated with fatalities reported to poison control centers. This overview offers a comprehensive look at cyclic antidepressants, covering aspects such as their biochemistry, clinical pharmacology, pharmacokinetics, clinical presentation, diagnosis, and essential management strategies for their inherent toxicity. This content provides 10 concise learning objectives aimed at fostering a comprehensive understanding of cyclic antidepressant toxicity. First, learners should be able to define cyclic antidepressants by explaining their chemical structure, historical background, and the variety of therapeutic uses they currently serve. They should also understand the importance of the low therapeutic index of these medications, recognizing how mechanisms and individual patient factors can lead to toxicity even when taken at therapeutic doses. Furthermore, learners need to describe the primary pharmacological mechanisms of action of cyclic antidepressants. These include effects such as sodium channel blockade and anticholinergic effects that contribute significantly to their widespread adverse effects and potential for severe overdose toxicity. It is also essential to summarize the pharmacokinetic and toxicokinetic properties of these drugs, including their absorption, extensive distribution throughout the body, hepatic metabolism, and elimination processes. Understanding these properties helps explain how toxicity can develop. In addition, learners should identify the characteristic clinical signs of acute overdose, which range from mild to moderate symptoms to severe toxicity, especially affecting the cardiovascular and central nervous systems. Recognizing specific electrocardiogram findings associated with toxicity, such as widening of the QRS complex and right axis deviation of the terminal part of the QRS, is also crucial, as these have important prognostic implications. The objectives include outlining the main management strategies for cardiotoxicity caused by these drugs, emphasizing the roles of serum alkalinization, and sodium loading with sodium bicarbonate. Developing an appropriate antidysrhythmic management plan is also key. This involves understanding the use of lidocaine for persistent ventricular arrhythmias and magnesium sulfate for torsades de pointes, while being aware of medications that are contraindicated. Additionally, learners should be equipped to manage seizures and hypotension related to overdose. This includes the use of pharmacological agents like benzodiazepines and vasopressors alongside critical supportive measures. Finally, an understanding of the role of intravenous lipid emulsion therapy in severe cases is necessary. Learners should evaluate its proposed mechanisms, current evidence for its effectiveness, and its recommended use, particularly in refractory situations. Cyclic antidepressants are a group of chemically related substances. They are historically recognized for their three-ring chemical structure. Some of these medications, such as maproteline, have a four-ring tetracyclic structure, while amoxapine features a dibenzoxazepine structure. These compounds share a common chemical framework composed of three aromatic rings, a central seven-membered ring, two outer benzene rings, and an aminopropyl side chain. Biochemistry and clinical pharmacology. The cyclic antidepressants are characterized by a distinct chemical structure that includes three aromatic rings. These consist of a central seven-membered ring, two outer benzene rings, and an aminopropyl side chain attached to the central ring. While these compounds are traditionally recognized for their tricyclic core, there are some minor structural variations among them, often involving the central aromatic ring or the aminopropyl side chain. Some cyclic antidepressants diverge from the typical tricyclic structure. For instance, maproteline is a tetracyclic antidepressant that features an ethylene bridge across a six-membered central ring. Another example is amoxapine, which has a dibenzoxazepine structure and is distinctive due to an aromatic substituent. It is derived from the antipsychotic medication loxapine. Cyclic antidepressants are classified into two categories: tertiary and secondary amines. This classification depends on the presence of a methyl group on their propylamine side chain. For example, the tertiary amines, amitriptyline and imipramine, are metabolized into the secondary amines, nortriptyline and desipramine, respectively. These secondary amines are also marketed as antidepressants. Cyclic antidepressants are medications that have a low therapeutic index, meaning there is a narrow margin between the therapeutic dose and a potentially toxic level. Even a small increase in the concentration of these drugs in the blood beyond the safe range can lead to toxicity. Severe toxicity most often occurs as a result of an intentional overdose, usually when an individual deliberately ingests a large amount of the medication. However, it is important to note that milder to moderate clinical toxicity can also occur even when cyclic antidepressants are taken at therapeutic doses, that is, within the prescribed range. This highlights the need for careful monitoring and appropriate dosing to prevent adverse effects. Maintaining awareness of these risks is essential for safe treatment with these medications. Several mechanisms and scenarios contribute to toxicity caused by therapeutic levels of cyclic antidepressants. The average therapeutic dose of these medications varies significantly, typically ranging from 1 to 5 milligrams per kilogram per day. Patients who start treatment at higher doses, or those who are new to the medication and unaccustomed to it, are more susceptible to experiencing adverse effects. Ingesting doses exceeding 5 milligrams per kilogram in children has been associated with clinical toxicity. The potential for pharmacokinetic and pharmacodynamic interactions exists when cyclic antidepressants are used in combination with other medications. Toxicity can occur if these drugs are administered together, especially when they possess similar pharmacological effects, such as antihistamines or antipsychotics. These interactions may lead to combined drug toxicity. In addition, many medications can inhibit the hepatic metabolism of cyclic antidepressants. This inhibition can cause an increase in the plasma concentrations of these antidepressants, thereby elevating the risk of toxicity even at therapeutic doses. Furthermore, some cyclic antidepressants are available in formulations that are combined with other agents such as benzodiazepines or antipsychotics. These combined formulations further increase the potential for drug toxicity due to additive pharmacological effects. Patient-specific factors can influence the effects and risks associated with cyclic antidepressants. Some individuals in the population are poor metabolizers of these medications due to genetic variations in the enzyme CYP2D6. As a result, they can develop significantly higher concentrations of the drug in their blood at any given dose, which increases their susceptibility to toxicity even when taking therapeutic levels. Patients with pre-existing medical conditions such as cardiac issues or seizure disorders are also more vulnerable to toxicity from cyclic antidepressants at standard doses. Vulnerability is particularly increased in geriatric and pediatric patients, as well as in those who are concurrently using medications that are cardiotoxic or depress the central nervous system. Age-related differences further impact drug concentrations and risks. Older adults may experience higher plasma levels of cyclic antidepressants due to decreased renal clearance. Conversely, in young children, even a single adult-strength pill can cause severe clinical effects, highlighting the dangers of unintentional ingestion in this vulnerable group. At therapeutic doses, certain toxicities associated with cyclic antidepressants warrant careful consideration. One significant concern is serotonin toxicity, which can occur particularly when these medications are taken alongside other drugs that increase serotonin levels. Another potential risk involves prolongation of the QT interval, a measure of heart repolarization. This effect can occur with both standard therapeutic use and overdose of cyclic antidepressants. It results from the blockade of myocardial potassium channels, which inhibits potassium efflux during repolarization and is often more pronounced at slower heart rates. A more severe complication is torsades de pointes, a life-threatening abnormal heart rhythm. Interestingly, this dysrhythmia is observed more frequently at therapeutic doses than with overdose. It has been postulated as a possible mechanism for sudden death in children taking these medications, although a direct causal relationship has not always been established. Therefore, it is recommended that cyclic antidepressants should not be initiated or continued in any child with a resting QT interval greater than 450 milliseconds or with a bundle branch block. Exaggerated side effects are also noteworthy, particularly in cases of chronic toxicity. These often manifest as amplified adverse effects such as sedation and increased heart rate, or as elevated drug concentrations in the bloodstream without an acute overdose. Serious toxicity remains rare at therapeutic drug levels, which are typically below 300 nanograms per milliliter. Beyond sodium channel blockade, cyclic antidepressants exert multiple other effects, including anticholinergic and antihistamine actions. These additional effects can complicate therapeutic use and may contribute to toxicity, emphasizing the need for careful management during treatment. Cyclic antidepressants are a class of medications known as non-selective agents. They exert a wide range of pharmacological effects. At therapeutic concentrations, these effects can be quite subtle. However, at higher plasma levels, such as those seen in overdose situations, these effects become less important. Only a few actions of cyclic antidepressants are believed to have a direct therapeutic benefit. Most of their other actions significantly contribute to adverse effects and toxicity during overdose. The key pharmacological actions of cyclic antidepressants include the inhibition of amine reuptake, which is considered the most important mechanism behind their effectiveness in treating depression. These medications are potent inhibitors of norepinephrine and serotonin reuptake, leading to increased concentrations of these neurotransmitters in the synaptic cleft and an enhancement of their responses. Tertiary amines, such as clomipramine, are particularly strong inhibitors of serotonin reuptake, whereas secondary amines are more potent in inhibiting norepinephrine reuptake. Chronic use of these drugs can also alter the sensitivity of central beta-adrenergic and serotonin receptors and can modulate the expression of glucocorticoid receptor genes. In addition to their effects on neurotransmitter reuptake, cyclic antidepressants possess anticholinergic or antimuscarinic effects. These drugs competitively inhibit acetylcholine at both central and peripheral muscarinic receptors, which is responsible for various side effects. These include symptoms such as sedation, agitation, delirium, confusion, dilation of the pupils, rapid heart rate, dry skin, bowel paralysis, and urinary retention. Cyclic antidepressants are powerful inhibitors of histamine receptors located both in the peripheral and central nervous systems. This inhibition primarily leads to sedation and may contribute to more severe outcomes such as coma and seizures in cases of overdose. Additionally, these medications antagonize alpha-adrenergic receptors, particularly those of the alpha-1 subtype. This action can result in central nervous system sedation, low blood pressure upon standing, and a reflex increase in heart rate. The blockade of alpha-adrenergic receptors also causes peripheral blood vessels to dilate, significantly contributing to postural hypotension. Sodium channel blockade is the most crucial factor contributing to patient mortality in overdose cases, as it can lead to life-threatening cardiotoxicity. Cyclic antidepressants inhibit sodium influx through voltage-gated sodium channels within the His-Purkinje cells and ventricular myocardium. This inhibition delays depolarization and results in conduction abnormalities observable on the electrocardiogram as prolongation of the PR and QRS intervals, as well as right axis deviation of the terminal portion of the QRS complex. Impaired sodium entry also decreases myocardial contractility and can cause hypotension. Additionally, cyclic antidepressants block myocardial potassium channels, inhibiting potassium efflux during the repolarization phase. This effect can be seen as prolongation of the QT interval on the electrocardiogram. Another potential mechanism involves antagonism of gamma-aminobutyric acid type A receptors, which may explain the generalization of seizures observed in approximately 10% of overdose cases involving these medications. Cyclic antidepressants have a low therapeutic index, meaning that a small increase in serum concentration above the therapeutic range can lead to toxicity. These medications are associated with the potential for severe cardiotoxicity in cases of overdose. They also often cause frequent adverse effects due to their nonspecific pharmacological actions. The cardiotoxicity risk is frequently the greatest threat to life among the adverse effects. Although the use of cyclic antidepressants for depression has decreased over time, they remain among the leading xenobiotics linked to fatalities reported to poison control centers. Amoxapine and maprotilene, despite having minor structural differences from traditional cyclic antidepressants, exhibit similar toxicity profiles in overdose situations. Amoxapine is particularly associated with a higher incidence of seizures. Maprotilene also demonstrates an increased occurrence of seizures, cardiac dysrhythmias, and prolonged coma compared to other drugs in the same class. These effects are partly attributable to amoxapine's potent inhibition of norepinephrine reuptake, its lack of effect on serotonin reuptake, and its blockade of dopamine receptors. The most frequently reported cyclic antidepressants involved in drug exposures in the United States are amitriptyline, doxepin, and nortriptyline. Outside of the United States, dothepin and clomipramine are commonly encountered in overdose cases. Understanding the biochemical and pharmacological properties of these medications is essential for managing toxicity related to cyclic antidepressants. Their activity at multiple receptors results in a complex clinical presentation, which necessitates targeted interventions for effective management. In the context of cyclic antidepressants, pharmacokinetics and toxicokinetics describe how these drugs are absorbed, distributed, metabolized, and eliminated by the body. This understanding is crucial both at therapeutic doses and in overdose situations, as it helps explain their therapeutic effects and their significant toxicity. Cyclic antidepressants are generally absorbed rapidly and almost completely from the gastrointestinal tract following normal therapeutic doses. The peak plasma concentrations are typically observed between 2 and 8 hours after ingestion, with some sources indicating that they occur between 2 and 6 hours. In cases of overdose, the absorption of cyclic antidepressants can be prolonged, This occurs due to their antimuscarinic effects on gut motility and the increased ionization in gastric acid. Distribution of cyclic antidepressants is characterized by their high lipophilicity, which enables them to easily cross the blood-brain barrier. These medications have a large and variable apparent volume of distribution, ranging from 10 to 50 liters per kilogram, indicating extensive distribution into tissues. They are rapidly distributed to vital organs such as the heart, brain, liver, and kidneys, where their tissue-to-plasma ratio often exceeds 10 to 1. Only a small fraction, about 1 to 2% of the total body burden of these drugs, is found in the blood. Cyclic antidepressants are extensively bound to alpha-1 acid glycoprotein in the plasma. Variations in the concentration of this protein or changes in blood pH can alter how the drug binds and the percentage that remains unbound. Specifically, a low blood pH, which is common in patients experiencing severe poisoning, increases the amount of free drug available, enhancing its effects. This property underpins the practice of alkalinization therapy in cases of overdose. Cyclic antidepressants undergo extensive first-pass hepatic metabolism, which results in low and variable oral bioavailability, typically ranging from 30% to 70%. However, this metabolism can become saturated in cases of overdose, potentially increasing bioavailability. The primary pathway for the elimination of cyclic antidepressants is hepatic oxidation, involving the endemethylation of the amine side chain groups and hydroxylation of the ring structures. The removal of a methyl group from tertiary amine side chains, such as an amitriptyline and imipramine, produces active metabolites like nortriptyline and desipramine. These metabolites often exhibit different pharmacologic activities compared to the original compounds. Additionally, these active hydroxy metabolites can contribute to toxicity. The metabolism process also involves glucuronide conjugation of the hydroxy metabolites, resulting in inactive metabolites. Genetic differences in the activity of the enzyme cytochrome P452D6, which is responsible for the hydroxylation processes, contribute significantly to variability in how individuals metabolize cyclic antidepressants. People with certain genetic profiles, known as poor metabolizers, tend to have higher plasma concentrations of the drug at therapeutic doses, putting them at increased risk of toxicity. Furthermore, the metabolism of cyclic antidepressants can be influenced by the concurrent ingestion of other foreign substances, such as alcohol, which can either induce or inhibit the activity of cytochrome P452D6, thereby affecting drug metabolism. The average elimination half-life of cyclic antidepressants at therapeutic doses typically ranges from 6 to 36 hours, with an approximate average of 24 hours. However, this can vary widely, spanning from 7 to 58 hours, and for the medication protriptyline, it can extend from 54 to 92 hours. In cases of overdose, the half-lives may be prolonged up to 72 hours due to saturable metabolism processes. A small fraction of the elimination of cyclic antidepressants, approximately 15 to 30%, occurs through biliary and gastric secretion. This process leads to enterohepatic and enterogastric recirculation of the metabolites, which are subsequently reabsorbed into the systemic circulation. Less than 5% of these drugs are excreted unchanged by the kidneys. Because of their large volume of distribution, high lipophilicity, and extensive binding to proteins in the blood, efforts to remove cyclic antidepressants through methods such as hemodialysis, hemoperfusion, peritoneal dialysis, or forced diuresis are generally ineffective. Additionally, attempts to increase urinary excretion by alkalinizing the urine do not improve and may even decrease the clearance of the medication. The prolonged absorption, large volume of distribution, high tissue binding, and long half-life in overdose all contribute to the low therapeutic index of cyclic antidepressants. These pharmacokinetic properties increase the potential for severe toxicity when these medications are misused. Additionally, the production of active metabolites means that toxicity from tertiary cyclic antidepressants often lasts longer than that from secondary cyclic antidepressants alone. Furthermore, Drug interactions with medications that inhibit hepatic metabolism can elevate plasma concentrations of cyclic antidepressants. This elevation can lead to toxicity even when the drugs are taken at therapeutic doses. The accumulation of cyclic antidepressants in tissues means that plasma concentrations do not always accurately reflect the severity of clinical toxicity, especially in cases of acute overdose. Patients may develop severe symptoms despite plasma concentrations being less than 1,000 nanograms per milliliter, and some individuals with higher plasma levels may not show severe symptoms. A distinctive characteristic of cyclic antidepressants is their ability to undergo significant postmortem redistribution. After death, plasma concentrations of these drugs can increase tenfold to 50-fold as tissue-binding sites release the medications back into the blood. This process complicates the determination of the cause of death in forensic investigations. The clinical presentation of an acute overdose is often rapid and unpredictable. Signs and symptoms usually develop within the first few hours after ingestion. The severity of cardiac and anticholinergic toxicity can vary greatly, ranging from mild symptoms to life-threatening coma and severe damage to the heart. It is important to recognize that initially, patients may show minimal clinical abnormalities. However, their condition can quickly worsen, leading to serious cardiovascular issues and central nervous system toxicity within a few hours. Key clinical manifestations of acute overdose involve a general progression that most commonly occurs within the initial hours after ingestion, often before the patient reaches the hospital. For individuals who are still alive upon arrival at the hospital and receive appropriate care, fatalities are rare. Patients who do not show significant toxicity within 6 hours of ingestion are considered to be at low risk for life-threatening complications. The most frequently observed initial effects include central nervous system sedation and sinus tachycardia. These, along with other anticholinergic effects, serve as important clinical indicators of toxicity caused by the substance. However, they are rarely directly responsible for fatalities when they occur in isolation. Mild to moderate toxicity may present as drowsiness, confusion, slurred speech, lack of coordination, dry mucous membranes and armpits, increased heart rate, urinary retention, muscle jerks, and hyperreflexia. Central nervous system depression often progresses to respiratory depression, which increases the risk of low oxygen levels in the blood and aspiration. Serious toxicity generally manifests within 6 hours of ingesting a large amount of the substance. It can involve coma, delays in cardiac conduction, wide complex supraventricular tachycardia, low blood pressure, respiratory depression, premature ventricular beats, ventricular tachycardia, and seizures. Secondary complications may include aspiration pneumonia, a lack of oxygen in the brain causing brain damage, high body temperature, and muscle breakdown. Acute respiratory distress syndrome is also recognized as a possible complication. Cardiovascular toxicity is primarily responsible for morbidity and mortality in cases of overdose. One prominent feature is hypotension, which results from direct depression of the heart muscle due to altered sodium channel function. This impairment reduces the heart's ability to contract effectively. Additionally, peripheral vasodilation caused by alpha-adrenergic blockade contributes to low blood pressure. Refractory hypotension, which does not respond to treatment, is the most common cause of death from overdose of cardiac agents. Factors such as low oxygen levels, acidosis, volume depletion, seizures, or the co-ingestion of other drugs that depress the heart can worsen hypotension. Sinus tachycardia is the most common abnormal heart rhythm observed in these cases. It often occurs at rates of 120 to 160 beats per minute in adults and is present in most patients with significant poisoning. This increased heart rate is caused by antimuscarinic effects, a reflex response to blood vessel dilation, and the sympathomimetic effects of cyclic antidepressants. Electrocardiogram abnormalities can serve as critical diagnostic indicators. Prolongation of the intervals between certain electrical impulses in the heart, such as the atrioventricular, intraventricular, and corrected QT intervals, is notable. Specifically, A widened QRS complex exceeding 100 milliseconds is a sensitive sign of toxicity and a heightened risk for seizures and ventricular dysrhythmias. When the QRS duration is greater than 100 milliseconds, there is approximately a 33% chance of seizures, and when it exceeds 160 milliseconds, the risk of ventricular dysrhythmias increases to 50%. A particular pattern called right axis deviation of the terminal part of the QRS complex is a classic finding. This deviation is often observed as a terminal R wave in lead AVR and an S wave in lead I on an electrocardiogram. A positive deflection greater than 3 millimeters in the terminal portion of lead AVR is also a significant predictor of seizures or abnormal heart rhythms. In addition, nonspecific abnormalities in the segments and waves of the electrocardiogram are common. More severe complications tend to occur when the QRS interval exceeds 100 milliseconds or when the right axis deviation of the terminal 40 milliseconds of the QRS complex surpasses 120 degrees. When electrocardiogram abnormalities are present, they typically develop within 6 hours of ingestion of a toxic substance and usually resolve within 24 to 48 hours. Ventricular dysrhythmias are characterized by wide complex tachycardia, which can be a potentially life-threatening condition in cases of severe toxicity. This type of dysrhythmia often reflects an aberrantly conducted sinus tachycardia rather than true ventricular tachycardia. However, true ventricular tachycardia may occur, particularly when there is a prolonged duration of the QRS complex or when the patient is experiencing hypotension. Although fatal dysrhythmias are uncommon, they do occur in approximately 4% of cases. The Brugada electrocardiogram pattern is rarely associated with overdose of certain substances. This pattern involves a right bundle branch block with an atypical pattern known as a rare RSR complex alongside downward sloping ST segment elevations in the electrocardiogram leads V1 through V3. Such findings suggest functional alterations in sodium channels, which are similar to those observed in cyclic antidepressant poisoning. The central nervous system toxicity caused by certain substances can lead to altered mental states. Symptoms such as delirium, agitation, or psychotic behavior with hallucinations are likely due to the antagonism of muscarinic and histaminergic receptors. These symptoms typically progress to lethargy and can eventually lead to a rapid coma. The duration of coma varies and does not always correlate with electrocardiogram abnormalities. Seizures are also common, particularly generalized and brief in nature. They occur in approximately 10% of cases involving overdose of certain substances, most often within 1 to 2 hours of ingestion. The risk of seizure increases with prolongation of the QRS complex on the electrocardiogram, especially when it exceeds 100 milliseconds. Furthermore, seizure-induced acidemia can worsen cardiovascular toxicity. Additional neurological manifestations include myoclonus and extrapyramidal symptoms. The mechanisms behind these toxic effects involve multiple pathways. Seizures induced by these substances may result from increased concentrations of monoamines, particularly norepinephrine, as well as from antagonism of muscarinic receptors, alterations in neuronal sodium channels, and inhibition of gamma-aminobutyric acid activity. Certain cyclic antidepressants are known to antagonize gamma-aminobutyric acid type A receptors in the central nervous system, thereby promoting seizures. There are various clinical effects associated with certain toxicities. One such effect is anticholinergic toxidrome, which is common among many sodium channel blockers, including cyclic antidepressants. These agents can cause pupillary dilation, although pupils may also be constricted or of intermediate size due to alpha-adrenergic blockade, offsetting dilation. Other signs include rapid heartbeat, dry mouth, flushed and dry skin, decreased bowel activity, or ileus and urinary retention. These symptoms are usually not severe, but can serve as indicators of toxicity. Respiratory depression is another critical effect, where depression of the central nervous system can lead to difficulty in breathing that may necessitate endotracheal intubation. The resulting hypoventilation and accumulation of carbon dioxide in the blood, known as acidosis, can worsen the intoxication. Pulmonary complications such as acute respiratory distress syndrome, aspiration pneumonitis, and multisystem organ failure can also occur as a consequence of toxicity. In the gastrointestinal system, diminished bowel sounds and ileus are traditionally linked to antimuscarinic syndrome. However, active bowel sounds can still be present even in seriously ill patients. Other gastrointestinal issues reported include bowel ischemia, pseudoobstruction, and pancreatitis. Factors that increase the risk include the dose ingested, co-ingestion of other medications, the patient's age, and pre-existing conditions. In adults, ingesting more than 10 milligrams per kilogram of the substance generally leads to life-threatening toxicity. Additionally, doses exceeding 1 gram are usually associated with severe effects in adults. In children, ingestion of more than 5 milligrams per kilogram can cause clinical toxicity, and even 1 or 2 adult-strength pills can result in serious effects in young children. Co-ingestion of medications that are cardiotoxic or depress the central nervous system can also elevate the risk. Furthermore, elderly and pediatric patients are at a greater risk of experiencing severe adverse effects. Patients with pre-existing health conditions such as heart disease or seizure disorders are more susceptible to these toxic effects. The diagnosis of cyclic antidepressant toxicity depends on a combination of patient history, clinical presentation, and specific diagnostic tests, especially electrocardiogram findings, since serum drug concentrations are often of limited usefulness in acute settings. In general, cyclic antidepressant toxicity should be suspected in any patient who presents after an overdose and shows signs of clinical toxicity or characteristic electrocardiogram abnormalities, or both. When diagnosing, it is important to consider other drugs that may produce similar symptoms. Although urine toxicology screens and serum drug concentration tests can confirm the diagnosis, they are frequently unnecessary during the initial stages of treatment because of their limitations and the risk of false negative results in early presenters. The electrocardiogram is regarded as the most effective screening test for cyclic antidepressant toxicity. Most patients with significant toxicity exhibit characteristic electrocardiogram changes within 2 hours of ingestion. Therefore, a combination of typical electrocardiogram alterations and clinical symptoms provides a sensitive and specific approach to diagnosing this condition. Electrocardiogram abnormalities are almost always observed in cases of significant calcium channel blocker toxicity and are crucial for identifying patients at increased risk for seizures and ventricular dysrhythmias. The typical electrocardiogram pattern associated with toxicity includes sinus tachycardia, as well as prolongation of the PR and QRS intervals. Additionally, a lengthening of the QT interval is commonly seen. A widened QRS complex exceeding 100 milliseconds is considered a sensitive indicator of toxicity. Specifically, a QRS duration of 100 milliseconds or more is associated with a 33% chance of developing seizures and a 14% chance of ventricular dysrhythmias. When the QRS duration reaches 160 milliseconds or more, the incidence of ventricular dysrhythmias increases to 50%. Another significant marker is right axis deviation of the terminal 40 milliseconds of the QRS complex. This can be identified as a terminal R wave in lead AVR greater than 3 millimeters and an S wave in lead I, or as a negative deflection in leads I and AVL. Such findings are sensitive indicators of drug presence and can predict the occurrence of seizures or arrhythmias. A less common pattern associated with calcium channel blocker overdose is a Brugada electrocardiogram pattern, also known as the type 1 or COVE pattern. This pattern resembles a right bundle branch block, but is rarely linked to overdose and lacks sensitivity and specificity for toxicity detection. Electrocardiogram changes are dynamic, which means that serial electrocardiograms are necessary for proper monitoring. When abnormalities in the electrocardiogram are to occur, they generally develop within 6 hours of ingestion. These abnormalities usually resolve within 24 to 48 hours. It is important to note, however, that life-threatening complications can happen even in the absence of significant electrocardiogram abnormalities. The risk of such complications is higher when the QRS interval exceeds 100 milliseconds or when there is right axis deviation greater than 120 degrees in the terminal 40 milliseconds. Qualitative tests for detecting cyclic antidepressant drugs in urine or plasma are highly sensitive but possess low specificity. This means that while they can effectively detect the presence of these drugs, they are also prone to yielding false positive results when other medications with similar structures are present, such as carbamazepine, diphenhydramine, and phenothiazines. Additionally, these tests do not distinguish between therapeutic and toxic levels of the drugs. Consequently, their usefulness in confirming acute cyclic antidepressant poisoning is limited unless supported by additional evidence. On the other hand, quantitative plasma concentrations of cyclic antidepressants are specific to individual drugs and have a low rate of false positive results. However, these tests tend to be costly and time-consuming, which makes them rarely practical in the setting of acute overdose, as results are typically not available promptly. Their primary application is in monitoring long-term therapy to ensure appropriate drug levels. The correlation between plasma concentrations of cyclic antidepressants and toxicity is notable. Plasma levels exceeding 1,000 nanograms per milliliter are often linked to significant clinical toxicity, including coma, seizures, and abnormal heart rhythms. However, severe toxicity can occur at lower concentrations below 1,000 nanograms per milliliter. Conversely, extremely high levels of the drug do not always result in seizures or ventricular dysrhythmias. It is important to note that serious toxicity is rare at therapeutic plasma concentrations, which are typically below 300 nanograms per milliliter. A unique feature of cyclic antidepressants is their ability to undergo significant drug redistribution after death. This process can cause plasma concentrations to increase tenfold to 50-fold as the drug is released from tissue-binding sites. Such post-mortem redistribution can lead to falsely elevated drug levels, potentially misattributed as the cause of death if not properly understood. Other initial laboratory studies include serum electrolytes, creatinine, and glucose concentrations, especially for patients with altered mental status. A blood gas analysis is crucial to assess acidemia and guide alkalinization therapy. A quantitative serum acetaminophen level is also indicated for all intentional overdose patients. The treatment of overdose involving cyclic antidepressants is complex and requires a multifaceted approach. It focuses on rapid stabilization of the patient, reversing life-threatening toxicities, and providing supportive care. This is especially important given the narrow therapeutic margin of these drugs and their potential to cause severe complications affecting the cardiovascular system and the central nervous system. Upon presentation, immediate assessment is crucial, particularly in evaluating any alterations in consciousness, blood circulation stability, and breathing difficulties. Every patient should promptly have an intravenous line established, be subjected to continuous cardiac monitoring, and undergo a 12-lead electrocardiogram. Serial electrocardiograms are essential for patients showing signs of toxicity to monitor changes over time. Laboratory studies should include testing serum electrolytes, measuring creatinine and glucose levels, and checking for serum acetaminophen, especially in cases of intentional overdose. It is important to note that asymptomatic patients initially may deteriorate rapidly, necessitating close observation for several hours. Early intubation is recommended for patients experiencing central nervous system depression or hemodynamic instability, as these conditions can lead to rapid clinical decline. Aggressive measures to maintain blood pressure and ensure peripheral perfusion should be implemented early to prevent irreversible damage. Overall, the management of cyclic antidepressant overdose requires vigilant monitoring and timely intervention to reduce the risk of severe complications. Gastrointestinal decontamination involves several procedures used to reduce the absorption of toxic substances. One such method is the administration of activated charcoal, which effectively binds cyclic antidepressants and minimizes their absorption. Typically, patients who have ingested a cyclic antidepressant within the past few hours should receive a dose of 1 gram per kilogram of activated charcoal. However, before administering it, the airway must be adequately protected to prevent aspiration, especially considering the risk of sudden mental status deterioration and seizures. Although activated charcoal is commonly used, its definitive impact on improving outcomes after cyclic antidepressant overdose has not been established. Usually a single dose is given, but in cases of severe poisoning where unabsorbed drug remains or desorption occurs, an additional dose may be considered, provided that no intestinal paralysis or ileus is developing. Cardiovascular toxicity is the primary cause of illness and death associated with certain medications. The main treatment approach for serious heart-related symptoms such as wide complex irregular heartbeats, conduction delays within the heart's electrical system, and low blood pressure involves increasing the blood's pH level through serum alkalinization and administering sodium to the patient. These interventions are especially important because cyclic antidepressants can cause severe damage to the heart, leading to significant health risks and increasing the likelihood of death. The use of serum alkalinization and sodium loading remains the cornerstone of therapy in managing these critical cardiovascular symptoms, aiming to reduce the risk of life-threatening complications. The mechanism of action for serum alkalinization and sodium loading involves two primary processes. Sodium loading works by increasing the concentration of sodium outside the cells, which helps to surpass the effective blockade of fast sodium channels in heart tissue. This is believed to occur through gradient effects, promoting the inward movement of sodium ions and thereby enhancing the rate at which electrical impulses are generated in the heart. Serum alkalinization, achieved by elevating the serum pH to approximately 7.50 to 7.55, serves a dual purpose. Firstly, it may decrease the binding of cyclic antidepressants to sodium channels, making the drugs less capable of exerting their toxic effects on the heart. Secondly, raising the pH reduces the free concentration of cyclic antidepressants in the blood, especially in cases of acidosis, which tends to increase free drug levels. This reduction diminishes the overall pharmacological impact of these drugs, thereby potentially lessening their cardiotoxicity. Indications for therapy include the use of serum alkalinization and sodium loading with sodium bicarbonate for patients who exhibit significant toxicity from cyclic antidepressants. Such toxicity is characterized by a widened QRS complex greater than 100 milliseconds, ventricular dysrhythmias or wide complex tachycardia, hypotension not primarily caused by hypovolemia, and seizures, especially in the context of cyclic antidepressant overdose. Conversely, prophylactic alkalinization in the absence of cardiovascular toxicity, such as when the QRS complex duration is less than 100 milliseconds, is not supported by current evidence. Initial therapy for this condition typically involves the administration of hypertonic sodium bicarbonate. The recommended approach is to give 1 to 2 milliequivalents per kilogram of body weight as intravenous boluses of an 8.4% sodium bicarbonate solution, administered at 3 to 5 minute intervals. These boluses should be repeated as necessary until the duration of the QRS complex narrows, the patient's blood pressure stabilizes, or a target serum pH level of between 7.50 and 7.55 is reached. In more severe cases, the required doses can be substantially higher, potentially involving the use of 10 to 30 ampoules of hypertonic bicarbonate. Following initial stabilization, a continuous infusion of isotonic bicarbonate can be used as a maintenance therapy. This process involves diluting 150 ml equivalents of sodium bicarbonate in 1 liter of dextrose with 5% water and administering it at approximately twice the typical maintenance rate, such as between 150 to 250 milliliters per hour. This approach aims to help maintain the target blood pH level. While isotonic bicarbonate is effective in elevating blood pH, its capacity to increase the sodium gradient across cell membranes is less than that of hypertonic solutions. Therefore, its use should be carefully considered based on the patient's specific clinical condition. Monitoring and therapeutic goals are crucial During alkalinization therapy, careful and frequent measurement of serum sodium and blood pH levels is necessary to guide treatment decisions and prevent potential complications. Electrolyte imbalances, such as hypokalemia and hypocalcemia, are concerns associated with bicarbonate therapy. These should be monitored regularly and corrected as needed. It is recommended to maintain serum potassium levels above 4.0 milliequivalents per liter. The primary therapeutic goal is to achieve a QRS duration of less than 100 milliseconds, if feasible, along with maintaining a moderately elevated blood pH within the range of 7.50 to 7.55. It is important to avoid excessive hypernatremia, given the hypertonic nature of bicarbonate ampoules. Additionally, excessive alkalinization should be avoided, as it may increase the risk of arrhythmias or seizures. Adjunctive methods for alkalinization include hyperventilation. In patients who are intubated, ventilator-driven hyperventilation can rapidly and controllably induce respiratory alkalosis and alkalinization. The target is to achieve an end-tidal carbon dioxide level of approximately 20 millimeters of mercury. However, this method is not as effective as using sodium bicarbonate alone when it comes to reversing cardiotoxicity. It is important to exercise extreme caution when combining hyperventilation with bicarbonate administration, as this can lead to severe alkalemia. This approach may be a reasonable alternative for patients suffering from acute respiratory distress syndrome or congestive heart failure, particularly in cases where administering large amounts of sodium is contraindicated. Hypertonic saline, which is a solution of sodium chloride at a concentration of 3%, has shown promise in animal studies. These studies suggest that hypertonic sodium chloride may be as effective as sodium bicarbonate in reversing cardiotoxicity caused by cyclic antidepressants. It achieves this by increasing the extracellular sodium concentration gradient. Although clinical experience supports the effectiveness of hypertonic saline, the optimal dosage for humans in terms of safety and effectiveness has not yet been established. Additionally, doses used in animal studies are often higher than what clinicians consider safe for humans. The use of hypertonic saline is not without risks. It can cause hyperchloremic metabolic acidosis, which is an undesirable side effect. Despite this, hypertonic saline may still be considered as an alternative if sodium bicarbonate is unavailable. The duration of therapy should generally be maintained for at least 12 to 24 hours after the electrocardiogram has normalized. This is important because there is a potential for cyclic antidepressant redistribution from tissues. The resolution of conduction abnormalities can vary significantly between patients. In some cases, it may take several days even with continuous bicarbonate infusion. It is often recommended to discontinue the alkalinization treatment when the patient's mental status improves. Additionally, there should be observable improvement in the electrocardiogram, although normalization of the electrocardiogram is not always necessary before stopping treatment. Patients experiencing cyclic antidepressant toxicity, especially those with impaired heart muscle contractility, are at increased risk of developing heart failure-related lung edema if too much fluids or sodium bicarbonate is administered. Once the patient achieves stability, the rate of fluid administration should be decreased to avoid further complications. While the use of alkalinization is generally accepted in treatment, it is not clear whether the failure of the electrical activity in the heart, specifically the narrowing of the QRS complex, to improve with sodium bicarbonate treatment definitively rules out cyclic antidepressant toxicity as the cause. The effectiveness of sodium bicarbonate in reversing a Brugada pattern on an electrocardiogram is also uncertain based on available literature. However, administering sodium bicarbonate remains a prudent choice if cyclic antidepressant toxicity is suspected as the cause. Antidysrhythmic therapy plays a vital role in treatment, especially because cardiovascular toxicity is the leading cause of illness and death. When managing dysrhythmias caused by cyclic antidepressants, the approach is guided by the underlying mechanisms, primarily the blockade of sodium channels. The The primary treatment for wide complex dysrhythmias, conduction delays, and low blood pressure resulting from cyclic antidepressant toxicity involves increasing the blood's pH level, serum alkalinization, and administering sodium. These methods help counteract the toxic effects as previously described. Lidocaine plays a crucial role as a secondary option in the management of severe ventricular dysrhythmias. It is typically used after the initial administration of sodium bicarbonate, which is considered the first-line treatment. The primary indication for lidocaine is in cases where dysrhythmias are refractory, meaning they persist despite previous sodium bicarbonate therapy. In particular, lidocaine is regarded as the preferred antiarrhythmic agent for ventricular tachycardia when hypertonic sodium bicarbonate has already been administered. Lidocaine is definitely indicated for situations such as recurrent ventricular arrhythmias that do not respond to bicarbonate therapy, as well as persistent cardiac arrest caused by ventricular tachycardia or ventricular fibrillation. It may also be used in cases of persistent hypotension when the patient has a prolonged QRS interval that is refractory to bicarbonate and other measures to improve circulation. This includes scenarios where the QRS complex is very wide and unresponsive to bicarbonate, especially if it is progressively widening and suggests an imminent risk of cardiac arrest. Lidocaine is classified as a Class IB antiarrhythmic medication. Unlike other sodium channel blockers, such as those in classes IA and IC, lidocaine does not affect phase 0 depolarization, nor does it prolong the QRS complex on the electrocardiogram. Instead, it may actually reduce the duration of the action potential and help narrow the corrected QD interval. The therapeutic benefit of lidocaine lies in its ability to compete for binding sites on cardiac sodium channels with toxic cyclic antidepressants. Because lidocaine is less toxic in this context, due to its lack of impact on phase 0 conduction, its binding can effectively improve sodium channel function. In theory, lidocaine may be more effective against cyclic antidepressants that bind to sodium channels for longer durations, such as amitriptyline and ertriptyline, compared to those that bind for shorter times, like imipramine or desipramine. The typical dose involves administering a slow intravenous bolus of 1 milligram per kilogram of body weight. This is usually followed by a continuous infusion ranging from 20 to 50 micrograms per kilogram of body weight per minute. Alternatively, a loading dose of 1 to 2 milligrams per kilogram of body weight can be given initially, followed by an infusion at a rate of 1 to 4 milligrams per minute. Removing the abbreviations and formatting the information into clear sentences enhances readability and understanding. Precautions and contraindications. Excessive administration of lidocaine can produce seizures. Therefore, caution should be exercised when using this medication, especially in patients who already exhibit seizure activity. Although phenytoin is also a Class 1B antiarrhythmic, it is no longer recommended for treating seizures or dysrhythmias caused by cyclic antidepressants. This change is based on evidence indicating that phenytoin can worsen ventricular dysrhythmias and fail to provide protection against seizures. Other antiarrhythmic medication classes are contraindicated in cases of severe overdose of cyclic antidepressants. Specifically, drugs in the first and second classes such as quinidine, procainamide, disopyramide, maricazine, flecainide, and propafenone should not be used. These medications all have sodium channel blocking actions that can worsen cardiotoxicity. Additionally, antiarrhythmic medications in the third class, including amiodarone, beryllium, and sotalol, are also contraindicated. These drugs tend to prolong the interval between heartbeats as seen on electrocardiograms, which can be harmful in this context. Beta blockers are generally not recommended because they may have negative effects on heart strength and function when used with cyclic antidepressants. Such combinations could lead to severe hypotension or cardiac arrest. Magnesium sulfate is an important agent for certain challenging medical situations. It particularly shows promise in treating ventricular arrhythmias that are resistant to other therapies. Magnesium sulfate has antidysrhythmic properties, which may make it beneficial in managing these abnormal heart rhythms. Although studies involving animals have produced mixed results regarding its effectiveness against dysrhythmias caused by cyclic antidepressants, there have been reported cases where magnesium sulfate successfully treated refractory ventricular fibrillation following an overdose of cyclic antidepressants. Additionally, one case-control study indicated that combining magnesium sulfate with sodium bicarbonate led to lower rates of death and shorter stays in the intensive care unit compared to using sodium bicarbonate alone. Clinically, if ventricular dysrhythmias persist despite efforts such as alkalinization, sodium loading, and administering lidocaine, giving magnesium sulfate can be considered a reasonable next step. For arrhythmias resistant to bicarbonate, a dose of 2 grams of magnesium sulfate administered intravenously may be effective. In cases of ventricular dysrhythmias, the typical dose ranges from 25 to 50 milligrams per kilogram of body weight, with a maximum of 2 grams, given intravenously over 2 minutes. Cyclic antidepressant medications can block myocardial potassium channels, which inhibits potassium efflux during the process of cardiac repolarization. This effect manifests on the electrocardiogram as a prolongation of the QT interval. Such prolongation can predispose patients to developing a dangerous type of arrhythmia called torsades de pointes, which can be life-threatening. Interestingly, torsades de pointes occurs more frequently in patients taking these medications at therapeutic doses rather than during acute overdoses. This paradoxical finding may be due to the protective effect of antimuscarinic-induced sinus tachycardia, which can cause a relative narrowing of the QT interval. The immediate treatment for torsades de pointes involves administering at least 2 grams of intravenous magnesium sulfate. It is also essential to investigate and rule out other possible causes of this arrhythmia. Additionally, overdrive pacing may be employed as a temporary measure to prevent the recurrence of this abnormal heart rhythm. Several medications are absolutely contraindicated because of their potential to worsen cardiotoxicity. Class 1 antidysrhythmics, including quinidine, procainamide, disopyramide, flecainide, and propafenone, have similar sodium channel blocking actions to cyclic antidepressants and can intensify inhibition. Class 3 antidysrhythmics, such as amiodarone, beryllium, and sotalol, are also contraindicated because they prolong the QT interval, which can lead to dangerous arrhythmias. Beta blockers and calcium channel blockers are not recommended either, as their combined negative effects on heart strength may result in severe hypotension and cardiac arrest. Additionally, the anticonvulsant medication phenytoin is contraindicated for seizures because it can worsen sodium channel blockade and increase cardiotoxicity. Flumazenil is contraindicated because it carries a risk of triggering generalized seizures. Furthermore, physostigmine should be avoided as it can induce seizures and elevate the risk of cardiac toxicity, including bradycardia and asystole. While phenytoin belongs to the same class of antiarrhythmic medications as lidocaine and shares similar fast-binding kinetics, it is generally considered contraindicated in cases of cyclic antidepressant overdose. This caution arises from several reasons related to its pharmacological effects and potential interactions. Limited clinical evidence and safety data are available for the use of phenytoin in this context, and they are less established compared to lidocaine. Phenytoin is a well-known anticonvulsant medication, but in cases of overdose, it can cause significant neurotoxic effects. These effects include difficulty with coordination, fatigue, and, in some cases, paradoxical seizures. Since overdose of cyclic antidepressants can also lead to seizures, the addition of phenytoin in this situation may complicate the clinical picture and worsen neurological status. Variable metabolism of phenytoin means that its breakdown in the body can become saturated. At high doses, a small increase can cause blood concentrations to rise disproportionately, significantly increasing the risk of toxicity. This unpredictability makes dosing particularly dangerous during an acute overdose. Additionally, intravenous formulations of phenytoin contain propylene glycol, a substance that can cause serious cardiovascular effects. Rapid infusion of these formulations may lead to cardiovascular depression, bradycardia, and hypotension. These adverse effects can further compromise a patient's cardiovascular state, especially in individuals who have overdosed on cyclic antidepressants. So, while both are Class 1B antiarrhythmics, their specific pharmacological profiles make them very different in a toxicological emergency. Lidocaine's ability to safely outcompete T-cyclic antidepressants for sodium channels without worsening conduction makes it a viable option, whereas phenytoin's unpredictable metabolism, central nervous system toxicity, and formulation-specific risks make it a dangerous choice. In the comprehensive management of cyclic antidepressant overdose, addressing low blood pressure is a crucial component. Refractory low blood pressure, which does not respond to initial treatments, can be the most common cause of death in these patients. Effective treatment strategies should focus on reversing the underlying heart-related toxicity and supporting the stability of blood circulation. This approach ensures better outcomes by carefully managing the critical aspects of the patient's condition. Physiological causes of hypotension in toxicity caused by cyclic antidepressants involve several mechanisms. Many cyclic antidepressants, including tricyclic antidepressants, block peripheral alpha-1 adrenergic receptors, leading to vasodilation. This vasodilation reduces systemic vascular resistance, which significantly contributes to hypotension. Additionally, cyclic antidepressants impair myocardial contractility by inhibiting cardiac sodium channels directly. This negative inotropic effect reduces the heart's ability to pump blood effectively, thereby decreasing cardiac output. Furthermore, various dysrhythmias, especially wide complex tachycardias and ventricular tachyarrhythmias, can result in hemodynamic instability and low blood pressure. Exacerbating factors such as hypoxia, acidosis, volume depletion, seizures, or the concurrent use of other drugs that depress cardiac function or cause vasodilation can worsen hypotension. These factors also predispose individuals to ventricular dysrhythmias. Moreover, downregulation of adrenergic receptors may blunt the physiological response to catecholamines, making the management of hypotension more challenging. The management of hypotension in cases of cyclic antidepressant overdose involves a systematic approach that prioritizes interventions directly counteracting the toxic effects of these medications. Initially, hypotension can be treated with isotonic crystalloids administered in increments of 10 milliliters per kilogram of body weight. However, it is important to recognize the limitations of this approach. Patients with impaired cardiac contractility may develop pulmonary edema if excessive fluids are given, and most patients are not hypovolemic, meaning that volume administration alone often proves ineffective. Consequently, it is crucial not to delay the initiation of vasopressor medications while evaluating the response to fluid therapy. When fluid administration is necessary, it is advisable to use balanced crystalloids such as lactated Ringer solution or plasmolite or isotonic bicarbonate solutions. These choices help avoid the promotion of acidosis, which can complicate the clinical situation. Sodium bicarbonate therapy was previously discussed. Vasopressors should be considered when a patient's hypotension does not respond to fluid therapy and sodium bicarbonate. The choice of vasopressor depends on the specific clinical scenario. Norepinephrine is generally regarded as the preferred vasopressor in cases of cyclic antidepressant overdose that involves alpha-adrenergic blockade. Its direct-acting mechanism is particularly beneficial because cyclic antidepressants can deplete intracellular catecholamines, reducing the effectiveness of indirect-acting vasopressors such as dopamine. Dopamine and epinephrine are also effective options. However, epinephrine may be more suitable for patients presenting with a slow heart rate. In cases where the patient experiences an abnormally rapid heart rate, phenylephrine may be a better choice. Additionally, vasopressin could be considered in refractory cases as it bypasses the alpha-adrenergic receptor entirely. Lidocaine is also discussed earlier. Advanced circulatory support is considered for cases that are refractory to initial treatment. In patients experiencing severe hypotension that does not respond to the maximum medical therapy, mechanical circulation support may be necessary. Various modalities are available for this support. These include cardiopulmonary bypass, veno-arterial extracorporeal membrane oxygenation, overdrive pacing, and assistance with an aortic balloon pump. These methods can provide critical blood flow to the heart and brain, helping to maintain the body's metabolic functions. This support allows time for the body to eliminate the cyclic antidepressant causing the condition. In managing toxicity caused by cyclic antidepressants, it is crucial to understand how to address seizures, as they pose a significant threat to patient safety and can worsen cardiotoxic effects. A comprehensive grasp of the mechanisms involved, the recommended treatments, and the agents to avoid is essential. The management of seizures induced by cyclic antidepressants focuses on rapid intervention to prevent further complications. The first-line treatment for ongoing seizure activity involves the use of benzodiazepines, such as lorazepam or midazolam. These medications are particularly effective because cyclic antidepressants inhibit GABA receptors, and benzodiazepines act as GABA receptor agonists, thereby helping to restore inhibitory neural activity. Typically, lorazepam is administered at a dose of 0.1 milligrams per kilogram intravenously, while midazolam can be given at a dose of 10 milligrams either intravenously or intramuscularly. Additionally, hypertonic bicarbonate solution is indicated in the treatment of seizures related to cyclic antidepressant toxicity. This approach helps to reverse acidosis and supports the proper function of cardiac sodium channels, which are often disrupted in such cases. Protection of the airway with endotracheal intubation is necessary for ongoing seizures or when the patient exhibits a depressed mental state. Immediately after intubation, hyperventilation should be initiated to achieve an end-tidal carbon dioxide level of approximately 20 millimeters of mercury. This helps induce mild respiratory alkalosis, which can counteract the worsening of cyclic antidepressant toxicity caused by acidosis. Barbiturates such as phenobarbital are indicated for seizures that recur or are resistant to benzodiazepine therapy. The initial intravenous dose of phenobarbital should be 15 milligrams per kilogram, administered in 5 milligrams per kilogram increments. Careful monitoring of blood pressure is necessary to watch for hypotension. Propofol is a short-acting intravenous anesthetic with anticonvulsant properties and may be used as a second or third-line agent for refractory seizures. It has been successfully used to treat refractory status epilepticus induced by amoxapine. If seizures persist despite adequate dosing of benzodiazepines, phenobarbital, and propofol, the next step involves neuromuscular paralysis and the administration of general anesthesia accompanied by continuous electroencephalographic monitoring. This approach ceases the physical manifestations of seizures and prevents secondary effects such as metabolic acidosis, hyperthermia, muscle breakdown, and renal failure. However, it requires ongoing anticonvulsant therapy to address persistent brain seizure activity. Phenytoin has been described earlier, but as a reminder, it is contraindicated. Flumazenil, a benzodiazepine antagonist, is strictly contraindicated in patients with known or suspected overdose of cyclic antidepressants, as its administration may trigger generalized seizures. Physostigmine, which has historically been used to counteract anticholinergic effects, is also contraindicated. Its use is limited due to its potential to induce seizures and increase the risk of cardiac toxicity, including bradycardia and asystole. Intravenous lipid emulsion has become an important consideration in therapy. However, there is ongoing discussion about its exact mechanisms of action and its appropriate role in treatment. Understanding the proposed mechanisms of intravenous lipid emulsion is essential for its careful and effective application. There are several possible mechanisms through which intravenous lipid emulsion may exert its beneficial effects in the context of cyclic antidepressant toxicity. One such mechanism is the lipid sink or lipid shuttle. This process involves the creation of an intravascular lipid sink, in which the highly lipophilic cyclic antidepressants are sequestered within the lipid emulsion droplets present in the bloodstream. This sequestration effectively reduces the concentration of free, unbound drug molecules that are available to exert toxic effects at critical receptor sites, such as the cardiac sodium channels and receptors in the central nervous system. The organization, known as the Medical Emergency Clinical Information Resource Project, also refers to this mechanism as a lipid shuttle, which helps transport the drug away from the heart. Intravenous lipid emulsion is believed to enhance the utilization of fatty acids, which serve as an alternative energy source for heart muscle cells. This effect is particularly important in situations where cardiac function is impaired due to drug toxicity, as it may provide the heart with a readily available supply of energy. Experts have elaborated on this, stating that intravenous lipid emulsion exerts direct beneficial effects on myocardial metabolism. This mechanism is considered more probable than the lipid shuttle explanation. The mechanism known as a direct cardiotonic effect suggests that intravenous lipid emulsion can enhance the contractility of the heart muscle directly. This improvement may lead to better overall cardiac output and blood pressure, which are often severely compromised in cases of cyclic antidepressant overdose. Additionally, intravenous lipid emulsion may influence ion channels within cardiac cells. It is proposed that the lipid emulsion can directly interact with and modify the function of various ion channels, potentially counteracting the inhibitory effects of cyclic antidepressants on sodium channels. In the larger context of managing toxicity caused by cyclic antidepressants, intravenous lipid emulsion is generally reserved for severe, life-threatening situations. Understanding the evidence supporting the use of intravenous lipid emulsion in cyclic antidepressant toxicity is essential for making informed clinical decisions. Although this treatment has gained attention in recent years, its role, especially regarding a patient's blood circulation and chances of survival, must be carefully evaluated based on the available scientific data. Evidence from animal studies suggests that intravenous lipid emulsion can be effective in cases of cyclic antidepressant toxicity. Several studies have shown that this treatment may improve survival rates and stabilize hemodynamic status in affected animals. For example, research has demonstrated that administering lipid emulsion either before or during resuscitation efforts can lead to better outcomes compared to conventional treatments such as saline controls or sodium bicarbonate infusion. These findings support the potential utility of lipid emulsion therapy in managing severe cases of tricyclic antidepressant overdose, although some results have been conflicting. A study conducted on rabbits found that intralipid was more effective than sodium bicarbonate in treating toxicity caused by the drug clomipramine. Conversely, another pilot study involving pigs compared the use of intravenous lipid emulsion to sodium bicarbonate for treating toxicity from tricyclic antidepressants. The results of this study showed that both treatments were equally effective in improving hypotension. However, some animal studies have yielded conflicting results. For instance, one study reported that intravenous lipid emulsion did not offer any benefit over sodium bicarbonate in reducing hypotension in a pig model. Additionally, another investigation observed that intravenous lipid emulsion could trap the antidepressant amitriptyline in plasma, thereby lowering its concentration in the brain of pigs. A recent study conducted on guinea pigs demonstrated that lipid emulsion infusion is more effective than serum alkalinization in reversing cardiotoxicity caused by amitriptyline. The findings suggest that using lipid emulsion therapy might provide a superior method for treating this type of cardiotoxicity. Evidence from human data, including case series and reports, indicates some clinical improvement with the use of intravenous lipid emulsion in cases of cyclic antidepressant toxicity. Although controlled human trials are limited, clinical experience suggests that this treatment can be beneficial, especially in refractory cases where other therapies have failed. Specifically, case reports have documented instances where patients experience cardiovascular collapse or instability that did not respond to conventional treatments. In such refractory cases, the administration of intravenous lipid emulsion has been associated with positive outcomes. For example, there has been a reported case where a patient with refractory ventricular fibrillation following an overdose of cyclic antidepressants was successfully treated using a combination of magnesium sulfate and intravenous lipid emulsion. The text discusses a case where a patient experienced a delayed-onset seizure followed by cardiac arrest after an overdose of amitriptyline. This patient was successfully treated using intravenous lipid emulsion. However, the reports on this treatment reveal that both the dosing and timing of administering intravenous lipid emulsion, as well as other concurrent therapies, vary significantly across cases. This variability makes it difficult to draw definitive conclusions regarding the overall effectiveness of the treatment. Evidence from controlled human trials is limited. A recent comprehensive review conducted by the Lipid Emulsion Workgroup identified only a single randomized controlled trial that examined the use of intravenous lipid emulsion in patients poisoned with cyclic antidepressants. This study found no significant differences between the intervention and standard therapy in terms of the time taken for electrocardiogram improvements, mortality rates, or the length of hospital stay. Given the well-established effectiveness of sodium bicarbonate, further research is necessary before intravenous lipid emulsion can be widely recommended as an antidote for toxicity caused by cyclic antidepressants. The current approach to using intravenous lipid emulsion in cases of cyclic antidepressant toxicity is nuanced. Typically, intravenous lipid emulsion is reserved as a third-line therapy for severe, life-threatening complications. It can be considered in situations such as recurrent arrhythmias, shock, or cardiac arrest that do not respond to other interventions. Specifically, it is regarded as a reasonable option for cardiac arrest resulting from cyclic antidepressant poisoning and for refractory hypotension or abnormal heart rhythms when other treatments have failed. Nonetheless, intravenous lipid emulsion should not be employed as a first-line treatment. It is also important that its use does not delay critical efforts such as sodium loading and serum alkalinization in patients experiencing cardiovascular toxicity. There is no evidence to support the use of intravenous lipid emulsion in cases of toxicity that are not immediately life-threatening. Furthermore, significant adverse reactions and complications have been associated with its use. These include acute respiratory distress syndrome, pancreatitis, and interference with laboratory tests. Overall, the application of intravenous lipid emulsion must be carefully considered within the context of the patient's condition and the available research evidence. There are no specific treatment methods that have demonstrated a clinically significant effect in enhancing the elimination of cyclic antidepressants. Multiple-dose activated charcoal can reduce the half-life of these medications, but it has not been shown to improve the severity or duration of clinical toxicity. Because of the large volume of distribution, high protein binding, and potential complications such as impaction or perforation, the routine use of this treatment is generally not recommended. Urinary alkalinization and forced diuresis are measures that have minimal impact on the overall clearance of cyclic antidepressants. In fact, urinary alkalinization does not increase urinary clearance and may actually decrease it by passive reabsorption of the non-ionized form of the drug. When considering hemodialysis and hemoperfusion, these techniques are ineffective due to the large volume of distribution, high lipophilicity, and extensive protein binding characteristic of cyclic antidepressants. Patients who remain without symptoms for at least 6 hours after ingestion have normal vital signs and a normal or baseline electrocardiogram and have completed a psychiatric evaluation for intentional overdose can be medically cleared for discharge. All patients who exhibit symptoms require hospital admission to a monitored bed. Those showing signs of moderate to severe toxicity, such as altered mental status, cardiac dysrhythmias or conduction defects, low blood pressure, respiratory depression, seizures, or a QRS interval longer than 100 milliseconds, should be admitted to an intensive care unit. For patients with significant poisoning, cardiac monitoring should continue for at least 24 hours after the discontinuation of cyclic antidepressant therapy, including treatments such as alkalinization, antidysrhythmic medications, and vasopressors. Monitoring is also necessary until the clinical toxicity has resolved. Cyclic antidepressants are a group of pharmacologically related chemicals, mainly characterized by their three-ring structure, although some variations exist. These drugs were the primary treatment for major depression from the 1960s through the late 1980s. Over time, their usage has expanded to include a variety of conditions such as chronic pain, migraines, and obsessive-compulsive disorder. A key feature of cyclic antidepressants is their low therapeutic index. This means that even a slight increase in their concentration in the bloodstream can cause toxicity. Such toxicity can occur even at doses used therapeutically and is often fatal if the drugs are taken in overdose. Key aspects of cyclic antidepressant toxicity and management include understanding their pharmacological actions. Cyclic antidepressants are non-selective agents with multiple effects on the body. The most critical mechanism that contributes to mortality in overdose cases is the blockade of sodium channels, which can cause severe cardiotoxicity. This cardiotoxicity includes delayed depolarization of the heart muscle and abnormalities in electrical conduction. Additionally, these medications exhibit anticholinergic effects such as sedation, delirium, rapid heartbeat, and intestinal paralysis. They also have antihistaminic effects that may lead to sedation, coma, and seizures. Moreover, blocking alpha-adrenergic receptors can result in orthostatic hypotension, which is a sudden drop in blood pressure upon standing. Potassium channel antagonism by these drugs can cause prolongation of the QT interval on an electrocardiogram, increasing the risk of abnormal heart rhythms. It is also noteworthy that certain drugs related structurally to cyclic antidepressants, such as amoxapine and maproteline, have a higher tendency to induce seizures. Cyclic antidepressants are rapidly absorbed after administration. However, in cases of overdose, their absorption can be prolonged due to antimuscarinic effects. These drugs are highly lipophilic, meaning they tend to dissolve in fats and have a large volume of distribution. This leads to extensive distribution into various tissues, so only a small fraction of the drug remains in the bloodstream. They undergo extensive metabolism in the liver through first-pass metabolism, often producing active metabolites that can contribute to their effects. The clinical presentation of an acute overdose is characterized by a rapid and unpredictable onset, often deteriorating into life-threatening cardiovascular and central nervous system toxicity within a few hours. Initially, the most common effects are central nervous system sedation and an increased heart rate known as sinus tachycardia. Cardiovascular toxicity is the primary cause of illness and death in such cases. It is characterized by low blood pressure resulting from weakened heart muscle function and dilation of blood vessels. Additionally, distinctive electrocardiogram abnormalities are observed, including prolongation of the PR interval, QRS complex, and QT interval. A widened QRS complex greater than 100 milliseconds serves as a sensitive indicator of toxicity and a risk factor for seizures and abnormal heart rhythms. A classic electrocardiogram finding is right axis deviation of the terminal portion of the QRS complex, such as a terminal R wave in the AVR lead greater than 3 millimeters. This appears as a predictor for seizures or abnormal heart rhythms. Interestingly, a type of abnormal heart rhythm called torsades de pointes is observed more frequently with therapeutic doses than during acute overdoses. Central nervous system toxicity can lead to altered mental status, ranging from delirium to coma, and may include generalized seizures. Such neurological symptoms occur in approximately 10% of overdose cases. The diagnosis is suspected in patients who exhibit clinical toxicity or characteristic abnormalities on an electrocardiogram. The electrocardiogram is considered the most effective screening diagnostic test for this purpose. Qualitative and quantitative drug screens have limited usefulness in the acute management of such cases because they can produce false positive results, do not reliably correlate with the severity of toxicity, and often have delayed results. Management of toxicities should focus on rapid stabilization and reversal of life-threatening conditions. Gastrointestinal decontamination can be achieved using activated charcoal at a dose of 1 gram per kilogram, but this is only indicated if it is administered within a few hours after ingestion and only if the airway is protected. In cases of cardiotoxicity, such as wide complex dysrhythmias, conduction delays, and hypotension, the primary treatment involves serum alkalinization and sodium loading with hypertonic sodium bicarbonate. This approach works by increasing the extracellular sodium concentration to overpower sodium channel blockade and by elevating the serum pH to between 7.50 and 7.55, which decreases the binding of cyclic antidepressants to channels and reduces the free drug concentration. For refractory ventricular dysrhythmias, lidocaine is the second preferred agent after bicarbonate therapy. It acts as a type IB antiarrhythmic, competing for sodium channel binding without worsening conduction. Magnesium sulfate is also vital, especially in the treatment of torsades de pointes, where a dose of at least 2 grams administered intravenously is effective, and it may be used for ventricular arrhythmias resistant to bicarbonate. Conversely, certain medications such as Class IA, IC, and third-generation antiarrhythmic drugs, as well as beta-blockers, calcium channel blockers, phenytoin, flumazenil, and physostigmine, are absolutely contraindicated because they can exacerbate toxicity or cause adverse effects. Hypotension can be initially managed with fluid boluses using isotonic crystalloids. If the patient remains hypotensive despite fluid administration, vasopressors such as norepinephrine are often preferred. In refractory cases where blood pressure remains unstable, advanced circulatory support, like extracorporeal membrane oxygenation or cardiopulmonary bypass, may be necessary. Seizures are typically treated with benzodiazepines such as lorazepam or midazolam as the first-line therapy. If seizures persist, barbiturates like phenobarbital or sedative medications like propofol are used as second-line treatments. Intravenous lipid emulsion therapy involves administering a fat-based solution that may work through mechanisms such as a lipid sink, which sequesters lipophilic drugs like cyclic antidepressants, and by providing direct metabolic benefits to the heart. This therapy is generally reserved as a third-line treatment for severe and life-threatening complications, including refractory cardiac arrest, shock, or abnormal heart rhythms. It is important to note that intravenous lipid emulsion therapy should not delay the administration of sodium bicarbonate. Existing evidence from controlled human trials is limited and indicates no significant difference in outcomes compared to standard therapies. Patients who show no symptoms and have normal vital signs and electrocardiogram results for at least 6 hours can be considered medically stable and ready for clearance. Conversely, patients exhibiting symptoms, particularly those experiencing moderate to severe toxicity, require admission to an intensive care unit and must be closely monitored continuously, especially their cardiac status. These patients should remain under observation for at least 24 hours after the toxic effects have resolved and after stopping antidepressant therapy that is specific to cyclic antidepressants.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.